Are you looking for study materials to help you pass your exams? We've newly released some content for pharmacy technicians. We've also got things for the NAPLEX exam for pharmacy students, and of course pharmacy board certification as well. So go support the sponsor, meded101.com/store. Your purchases there go directly to help support this podcast and keep it a free available resource for all those to benefit from. So go to meded101.com/store and help get started on passing your exam today. Hey all, welcome back to the Real Life Pharmacology Podcast. I'm your host, pharmacist Eric Christensen. Thank you so much for listening today. As always, go check out reallifepharmacology.com. Get your free 31-page PDF. Simply an email will get you access to that. That's a 31-page PDF on the top 200 drugs. So great refresher, great no-brainer to have for your reference there. So take advantage of that. With that said, let's get into the 5 drugs of the top 200 I'm going to cover today. So we've got drugs 76 through 80. First one is metoclopramide. Brand name of this medication is Reglan. This medication, what I've seen in practice, it's most often used for gastroparesis, so that's the slowing down of the gut, as well as nausea and vomiting. So those are the two primary indications there. So metoclopramide mechanistically inhibits gastric smooth muscle, and it does this by blocking dopamine receptors. So if you can remember some of the previous medications we've covered, antipsychotics specifically, antipsychotics block dopamine as well. So you could anticipate there may be some overlap there as far as adverse effects. And with that said, metoclopramide has the potential to cause some movement type adverse effects. Abnormal involuntary movements can lead to tardive dyskinesia. And that's a really, really important thing to remember. And probably the patient population that is most important to remember is patients with Parkinson's. So patients who already have a pre-existing movement disorder. Recall that a lack of dopamine is the issue in Parkinson's disorder. And by using a drug like metoclopramide, we are going to actually worsen by blocking dopamine receptors. So we can worsen Parkinson's disease. Other adverse effects, hyperprolactinemia is also associated with this medication due to that dopamine blocking action as well. But again, probably the most highly testable thing that you're going to see is recognizing that metoclopramide can block dopamine and certainly can worsen something like Parkinson's disease. From a drug interaction standpoint, the biggest thing that I think about with this medication is due to that dopamine blocking action. So if we're trying to use dopamine agonist, or we're trying to increase the amount of dopamine, so dopamine agonist, for example, would be a drug like pramipexole. A dopamine enhancing or increasing medication would be medication like carbidopa-levodopa, brand name Sinemet. So again, metoclopramide is going to block the beneficial effects of the dopamine agonist, or increasing dopamine activity there. All right, next medication is Relafen. That's the brand name, The generic name is nabumetone. Mechanistically, this is considered a non-selective inhibitor of COX-1 and COX-2. Classification, this is obviously an NSAID, if you remember that mechanism of action. So that inhibition of COX enzymes leads to a reduction in inflammation and a reduction in pain signals as well there. Primary uses of an NSAID like nabumetone, obviously any type of pain, inflammation type syndrome, rheumatoid arthritis, osteoarthritis, those type of pain syndromes, NSAIDs can certainly be helpful for, and that's the most common use you're going to see them in practice. I will say I don't see nabumetone used terribly much anymore. In general, with NSAIDs, obviously there's lots of concerns, and particularly in our elderly population. So it's ideal to use NSAIDs short term and obviously minimize dose if at all possible there. There is GI bleed risk with NSAIDs, so that's particularly troubling, especially as patients get older or if they've got a history of GI bleed. Keep an eye on those patients, those polypharmacy patients who, maybe they have atrial fibrillation and they're taking anticoagulant. Maybe they're on, maybe they've had a heart attack, an MI, and they're taking, clopidogrel, or they're taking aspirin. This can increase the risk for GI bleed. So really, really important to recognize that with NSAIDs. Now, digging a little bit deeper on the mechanism, nabumetone may trend a little bit more towards COX-2 inhibition versus COX-1. So potentially, if you think about celecoxib, which is classically considered as probably one of the most COX-2 selective agents, those COX-2 selective agents tend to have a lower risk for GI bleed. But with nabumetone, the higher the dose you get, the more and more likely it is that medication is going to be non-selective, and we can increase GI bleed risk further. In comparison to, let's take nabumetone in comparison to indomethacin, for example, or ketorolac. Those tend to cause higher rates of GI bleeding. CHF is an important thing to remember. So patients with heart failure using NSAIDs can increase sodium and water retention, and that can potentially exacerbate heart failure. So definitely pay attention to that. That's always a highly testable thing to look out for there as well. Probably a little less common, maybe they can contribute to resistant hypertension as well. So if you see somebody with escalating doses of blood pressure medications, take a peek at that and make sure that they're not on an aggressive dose of NSAID that may be worsening that hypertension. And then last but not least, as far as the risks associated with NSAIDs, they can worsen kidney function. So obviously that's an important monitoring parameter, and we need to pay attention to other medications that may cause insult to the kidney. Let's talk about diuretics. I'll mention ACE inhibitors or ARBs. Those used in combination with an NSAID like nabumetone may increase that risk for acute renal failure. In addition to renal function, CBC, anemia, bleed risk is going to be an important monitoring parameter. And there is a potential increased risks. This is a class effect for cardiovascular events as well. So definitely a warning to pay attention to there too. Drug interaction standpoint, I worry about anticoagulants, antiplatelets, and then drugs that can exacerbate renal function. Those are usually my main focus with drug interactions and nabumetone. All right, number 78 is cephalexin. Brand name is Keflex. This is an antibiotic for infection. It is a first-generation cephalosporin. It comes in oral formulations. It's not available IV or anything. And it's important to remember with cephalosporins, this is a generalization a little bit, but the earlier the generation of cephalosporin, so Keflex is a first generation, one of the originals, the more gram-positive coverage these medications tend to have. And indeed, with cephalexin, we're primarily looking at Staphylococcus and Streptococcus species that are going to be covered with the use of this medication. Now, I will say it's not MRSA that cephalexin is going to cover here. The mechanism of action, this medication binds to penicillin binding proteins in bacterial cell wall. leading to the inhibition of cell wall formation and ultimately death of the bacteria. Those dosage forms, capsule, tablet, and suspension, those can be important depending upon what patient population you're treating. Obviously, if we're looking at pediatrics, we might be using a suspension. Some indications that I most often see this medication used for, strep throat, skin and soft tissue infections, mastitis. I will say with strep throat, typically we're going to use a penicillin antibiotic first. That's at least the go-to, I would say, in clinical practice for most clinicians. But cephalexin does have some activity there against it as well. Adverse effect profile, you can think of it pretty similar to penicillin antibiotics and many antibiotics. GI upset, nausea, vomiting, diarrhea, that can certainly happen. And then, rash, itching, hives, skin reactions, those can happen as well. So important to recognize that it's going to have a similar adverse effect profile to most of the penicillin antibiotics. All right, next medication is Venlafaxine. Brand name of this med is Effexor. Mechanistically, this is an SNRI, so it inhibits both serotonin and norepinephrine reuptake in the brain. Primary uses, anxiety and depression. I think of Venlafaxine as somewhat close to duloxetine, or brand name Cymbalta. However, I would say Venlafaxine probably has a little less evidence in using it for pain syndromes. We typically need to get to higher doses of Venlafaxine to maybe get more pain benefit compared to duloxetine, and so that's typically why, or one of the reasons why you're going to see duloxetine used for pain syndromes compared to Venlafaxine. Venlafaxine has a relatively shorter half-life, and with that, you may experience a little bit more significant withdrawal. So if you see a patient on, 150 milligrams a day, 225, some, moderate to higher dosages, we're definitely going to want to try to taper that Venlafaxine so we don't run into some of those antidepressant withdrawal symptoms. And I've blogged about SSRI withdrawal symptoms and SNRI withdrawal symptoms. If you just Google search MedEd 101 and SSRI withdrawal symptoms, that'll kind of give you a good flavor for what you might see in that situation. Other adverse effects potentially can raise blood pressure. This is particularly true at higher dosages. How clinically significant that is and how often I see it, I can't say I see it terribly often. But with that said, if I've got a patient on multiple 3, 4, 5 blood pressure medications and they still can't seem to get it under control, definitely Venlafaxine comes to mind as a medication I should look out for as far as contributing to that hypertension, particularly at higher dosages. Sexual dysfunction is a potential adverse effect there as well. Always good to ask and recognize that when working with patients. From a drug interaction standpoint, probably the biggest thing I worry about is those serotonergic drug interactions and risk of serotonin syndrome. Generally, we avoid the use of Venlafaxine with MAOI, as it is truly contraindicated there. But tricyclic antidepressants, SSRIs, we're kind of having some overlapping mechanism of action there. So, really, ideally, we shouldn't be using any of those together either. All right, last but not least, we've got number 80, and that is ibandronate. Brand name of this medication is Boniva, and this medication is a bisphosphonate. It inhibits osteoclasts, and if you remember what osteoclasts do, they break down bone to help pull in calcium into the bloodstream and basically increase calcium levels. So if we think about inhibiting that action, we can anticipate that calcium is going to stay in the bone and it's going to help in the management of osteoporosis. Ibandronate does come as an oral agent. That's typically given once monthly, and an IV agent as well. That IV is given 3 milligrams every 3 months. It's been quite some time since I've seen anybody on the IV ibandronate. That's fairly burdensome for patients if they've got to get an IV every 3 months. Recall that bisphosphonates are first-line osteoporosis therapy. Obviously, if they don't have any contraindications. Ibandronate, it definitely isn't preferentially used within that bisphosphonate class. You certainly see much more alendronate and risedronate because one of the primary reasons is they have the best evidence for vertebral and hip fracture prevention. Adverse effect profile. So using the oral ibandronate, we have esophageal concerns. If patients cannot remain upright for a long enough period of time after they take that medication, or they have significant esophageal history or esophageal concerns, this is probably a patient population we're going to avoid this medication, at least the oral formulation. Important education point, make sure to educate patients about the administration procedure, remaining upright for 30 to, and more ideally, 60 minutes, full glass of plain water with no other meds, food, etc. So, again, very, very important education point there in patients taking ibandronate orally. Adverse effect profile, osteonecrosis. This is a very rare adverse effect. I have seen this come up on exams. I've only seen it in practice probably once or twice. Again, very, very rare, but definitely something that you might have patients ask you about. Hypocalcemia. So mechanistically, if you go back and listen to when I talked about the mechanism, that osteoclast inhibition, as you could anticipate, we do have the potential for hypocalcemia, so pay attention to that. Be a little cautious in patients with impaired renal function. So generally, it's recommended to avoid the oral agents or oral bisphosphonates when patients' EGFR, creatinine clearance, gets less than 30 mils per minute. So if you got somebody borderline, that's definitely a good thing to look at and make sure we're reassessing risk versus benefit there. With bisphosphonates, significant consideration should be given to discontinuing that medication after 5 years of use. Higher risk patients may continue on the medication for longer periods of time, but at that 5-year point for oral bisphosphonates is a good time to kind of reassess that. From a drug interaction standpoint, so I worry about GI risks. So particularly in patients maybe taking NSAIDs on top of a bisphosphonate, that potentially is a little bit of a double whammy on the esophagus. So recognizing that risk, I think, is really, really important. And then the other thing is the administration and drug interactions, not giving this medication with other medications that can bind it up and potentially block absorption and make taking the medication basically useless if we're giving it with other medications and food and things like that. So a couple of important things there with regards to drug interactions and the use of ibandronate. All right, well, I think that wraps up the podcast for today. Do me a huge favor, support meded101.com/store. We've got Naplex resources, BCPS, ambulatory care, BCMTMS, all sorts of great study materials that can definitely help you prepare for and pass your exam. So go support meded101.com/store. If you want to reach out to me, you got any questions, mededucation101@gmail.com, or you can connect with me on LinkedIn as well. Eric Christensen, PharmD, BCPS, BCGP. Do me a huge favor, share this with friends, colleagues, leave a rating or review. All those things are helpful to help me with this podcast, grow the audience, and obviously help educate more people, more healthcare professionals about the appropriate use of medications and pharmacology in general. So greatly appreciate that. Thank you all so much for listening. Hope you picked up a few practice pearls today or helped you out with your exam a little bit. And yeah, hope you have a great rest of your day.